Well, globally, the number of women who die during childbirth is quite alarming. But what really leads to the death of expectant mothers? We are highlighting women issues during this month of August, and we are very pleased to welcome on the line Dr Yogan Pillay from the Department of Health to try and shed more clarity on this matter for us. Dr Pillay, a very good afternoon. Thank you so much for joining us. Why are these figures so alarming and keep on increasing in terms of maternal mortality? We're hearing 830 women die daily during childbirth, sir.
Lisa, thanks very much, and good afternoon to you and to your viewers. Yes, indeed, globally, the maternal mortality ratio is still much higher than anyone would like to see. And that's one of the reasons the Sustainable Development Goals has one of its targets to reduce maternal mortality globally and in every country to no more than 70 per 100,000 women who deliver by 2030. So that's the global target, and you can see that as you quoted a very much higher number, we still have a long way to go. The major causes of maternal mortality, certainly in South Africa, are threefold. One is HIV, which we've, of course, known now for the last 25 to 30 years. The second is pregnancy-related hypertension. And the third is obstetric hemorrhage. That's bleeding either before, during, or after delivery. So those are the major clinical causes of maternal mortality in South Africa, and they're pretty much similar throughout southern and eastern Africa.
All right, look, Doc, you've just unpacked the clinical causes, but let's unpack the social ones. I mean, we do understand that I was looking at research that actually indicates that the deaths occur normally in rural areas as well as poorer communities. But these reasons are just not substantial, Doctor. Why can't these women have the same access to better healthcare services as the rest of the women in the country?
So it's true that women living in rural areas have more limited access to health services, and that is a condition that applies really throughout the world. And that's not to excuse the fact that we must make access more acceptable and accessible to poor women and rural women. There are a couple of things we are doing to ensure that we get better access. One is to decrease the distance between health services and women, especially those living in rural areas. And we are using cell phone-based technology called mHealth to increase access to information, to knowledge. We are using mobile clinics to reach out to women. We are using community health workers to reach out to women in rural areas. So there are a number of things we are doing, both using technology and human resources, to try and decrease the distance between women in rural areas in particular and our health services.
And then, Doctor, look, I was also reading on that research that the clinical causes that you actually did, in fact, highlight earlier on, that some of these are actually preventable, but just that these women don't know that they do have access to these measures. Talk to us about how then you get the message across that these women that might be experiencing any of these symptoms can actually go ahead and eventually save the life of themselves and their child.
So the one area where we have been focusing is community health workers, to decrease the distance between families, homes, communities, and health facilities. In South Africa, we have upwards of 54,000 community health workers in every corner of our country, and there are obviously more of them in rural areas. And we are in the process of strengthening those services. Secondly, we are asking women, and we have very high level of cell phone penetration in South Africa. Upwards of 90% of households have cell phones of one type or another. And the idea is to provide women with weekly messages related to their stage of pregnancy they are in, basically telling them what to expect both in terms of their own health, the health of the fetus, as well as what to expect when they receive antenatal care. We've also improved the number of antenatal visits that a mum could make from 4 to 8. And we are asking that women attend antenatal clinics from 14 weeks, from when they're 14 weeks pregnant, through to 40 weeks, with an increase in the number as they reach week 30. And from week 34, we are expecting them to attend clinics more frequently between weeks 34 and 40.
All right.
And that would enable us to detect problems and intervene much earlier, which would save the mom's life as well as the baby's life.
All right. And Doctor, I mean, while we're still there, we're always hearing reports in the news about the treatment by staff members of these government facilities towards these pregnant women, that they don't even want to go to those places to seek any help. Are you looking at better training of staff and better management of schedules? Because we're always hearing that there's staff shortages that lead to actually people not delivering on their duties. Are these some of the things that you are part and parcel of the 2030 markup?
No, indeed. The World Health Organization published last year a new framework focusing on person-centered healthcare services with 6 different strategic objectives. And clearly one of them is to improve the attitudes, respect, and quality of healthcare provided to patients, including pregnant women. We have been piloting a project in South Africa that's focusing specifically on retraining nurses and midwives on the provision of what's called respectful care to pregnant women. So we are doing a large number of things to improve the patient experience, to decrease the distance between patients and pregnant women in our facilities. And might I add, Alicia, that we are also improving access to contraceptives because we want families to be planned and not a consequence of unplanned and unwanted pregnancies.
Absolutely.
So we are also improving access to contraceptives.
Absolutely. And Doctor, I mean, talk to us about this. I mean, are you also providing more information, particularly to those poorer and rural communities, about the different types of birth plans, particularly that you don't necessarily have to go and give birth in hospital, like you just mentioned now? There are some home births that are pretty synonymous with rural areas, but that is actually where the kids die or the mothers die because the midwives, they don't have the necessary information.
You know, the good thing about deliveries in South Africa is that the bulk of the deliveries of babies in South Africa are in our health facilities. And of course, that improves also the care that can be provided. We also make provision for maternity waiting homes. So pregnant women, especially in rural areas, can come to our hospitals and stay before they are expected to deliver. And here, in particular, we are encouraging women who have difficult pregnancies to come and admit themselves early before they deliver, so that if there are any challenges with the pregnancy and delivery, it can be done safely in our facilities.
All right, Doctor, thank you so much. We're going to leave it there. Thank you so much for that sound update. That is Dr. Yogan Pillay. He is with the Department of Health, and he was talking to us about the worrying trend of maternal mortality.